Well, thank you all for the opportunity to speak on this topic. So I always ask, where does our story begin? And that's really important to understand when we want to talk about age of start screening. And you've all seen this numerous times where we show this prevalence occurring in young women. However, if you look at the x-axis, it just says less than 20. So I always kind of consider this, if you extend this, this kind of looks like the US fiscal cliff, where we don't really know what almost exists behind this curve. So if you extrapolate that curve, it means we're all born with HPV. But we don't believe that that's where our story begins. In fact, the cancer story begins right here. So with that first sexual encounter, it's a matter of time. The clock is ticking. These are little HPVs making their way to the cervix. And we see that within basically 3 years after the onset of sexual activity, approximately 50% of young women are going to acquire a high-risk HPV type. And we know the #1 risk factor is having a new sex partner. So we showed that there was a 10-fold risk for every new partner per month. This is an extremely easily sexually transmitted infection. We know the probability for perhaps each per act of acquiring an HPV is anywhere between 5 and 100%, with probabilities reaching about 100% for all types after only 11 acts of sexual intercourse. This was a study we did in young monogamous couples. They were ages 18 to 24. We asked them to have sex on Sunday, and we then saw them 24 hours later. And what you can see are two things that are fascinating here. One is, at any one point in time, they shared, 75% of them shared at least one HPV type. Within 24 hours, it went up to almost 95%. So this kind of switching and going back and forth is enormous. And over 6 weeks, again, any one point in time, they shared at least, 75% of them shared at least one type. Now, perhaps interesting too here is we showed that around 50%, if they had it in the genital, their partner had it in either the anal area or their partner had it in the hand. So once again, be careful where you sit. HPVs everywhere. We've also seen this where we see young women tend to be incredibly vulnerable to HPV incident more than older women. I always say that's a good reason for growing older. Somehow you get protected from this. So what's probably very relevant to young women is the squamous metaplastic process on the cervix. And this process, as we understand HPV, basically supports viral replication through the own cellular replication differentiation that is so acute in young women. So what does this mean? Basically, we did in a study where we showed change in that area of metaplasia, suggesting this was very active. And so for every 3-fold change we saw, a woman was going to develop a low-grade SIL lesion. So because of this, when you look at young women, they are the most likely group to have abnormal cytology. And this is in the US, over 10,000 smears showed abnormal cytology was most likely to occur in young women aged 10 to 19 years of age. So we also know, this is the good part of the story, that young women can clear this infection. At least 90% will clear their HPV infection, and 90% will clear their low-grade SIL lesions. So that's it. We even have more HPV coming in young women. It's only a matter of time. So in this study, we showed if a young woman had one HPV infection, 80% of them would go on to a second. If they had 2 infections, 70% went on to a 3rd infection. So it's not even that one infection we're seeing. We're seeing multiple infections occur over and over, and all of these infections were related to sexual behavior. That is, new partners is what drove acquiring another infection. So this is what adolescence really looks like. It's a lot of coming and going of abnormalities. Also, I just want to identify that this area of squamous metaplasia, in the same extent that we think it's vulnerable to acquiring perhaps HPV infections and low-grade SIL, it's also important for that clearance. We did a study looking at cytokines in these women who had large areas of ectopy versus small. And what we found are cytokines were 10 to 100-fold higher, specifically ones like IL-1 alpha, IL-1 beta, IL-6, which we all think are now very important immune cytokines correlated with viral clearance. So treating squamous metaplasia in young women may actually be quite harmful. So we also know that persistence in those few is also a risk factor for CIN2. So what is CIN2 in adolescents? Well, we did a study looking at 13 to 24-year-old women at Kaiser, and we followed them and found that without treatment, about 70% would clear their CIN2 lesions. And not surprisingly, the 16-18 were slower, but the non-16-18, 80% of those infections cleared. So also in young women, the story of adolescence is all of this, and the majority of this is going to go away. So we ask our questions when we talk about age to start screening, do they get cervical cancer? Well, it's extremely rare in the US, with about 1 to 3 cases per million of 15 to 19-year-olds, and it raises about tenfold in the 20 to 24-year-olds, still very small number of cases. And we know nothing about these cases. Are they immunocompromised individual, renal transplants? Well, this study by the CDC showed many of these infections in young women, in fact, are not squamous cell carcinomas, they're sarcomas. And probably screening is not really going to identify these young women. So when we look at prevention, is screening a benefit in adolescents? Well, my colleague who's going to be speaking next actually showed in young women aged 22 to 24, if you screen them and then you look at the next 5 years, they have no benefit. Whereas you look at older women, they are much more likely to have benefit, and we know that. We've changed cervical cancer rates. Well, why is it that screening may not be helpful in adolescents and young women? Because if they get cancer, it may be an extremely aggressive cancer. It may be sarcoma, or they may be immunocompromised, where again, the time is so fast that before you screen, you're going to end up with cancer. So is screening a risk? Well, we've also seen this, that actually treating this, as I had mentioned earlier, may get rid of a woman's own innate immune responses, but also there's evidence that a preterm delivery may in fact be a risk from having treatment. And I also point this out, in our study that looked at CIN2 progression to CIN3, we found that, not by surprise, HPV persistence was important. But at entry, having 16 and 18 was not as strong as a risk factor. Why? Because even over 3 years, many of those women had CIN2-3 not due to the same type that they entered into the study. A lot of these infections are coming and going, including their CIN2s. So the old guidelines in the US said we would be cervical cancer screening within 3 years of the onset of vaginal intercourse. That means some of women, 15, 16, 17, were already being screened. However, who would go shopping in the middle of a storm? It's much better to wait until things calm down. So we currently now recommend to start screening at the age of 21 because, again, we feel that some of these things may be more harmful than helpful in young women. But why 21 versus 25? Well, in the US, we do not have population-based screening programs. We do not have call-recall programs. So the age of 21 is considered safer in order to get the adequately screened populations. Also in the US, cervical cancer screening is considered a failure if we identify cancer. It's really a success in the US if we detect precancers to prevent cancers. I also want to show a couple of studies that begin to support our current guidelines. These are comparing the Netherlands, which starts screening now at the age of 30, compared to the US that screens at the older guidelines I'd mentioned. And what you see here is, despite our very aggressive screening, that in older age groups over 30, the prevalence has decreased almost identical. But here in the US, our young women under 30 continue to have a decline, specifically those cancers in that age group. Whereas here in the Netherlands, you can see that there currently is no decline. Even again, these numbers are extremely small. In Iceland, they've also shown that younger women, probably with different sexual practices, we're seeing a younger age of the onset of cancer, which begins now to rise at 25 with a peak in the 30s. And they also showed evidence to show if you start screening young women, again in this slightly older cohort here between 89 and 2003, that the CIN rates of 14 per 100,000 are almost identical to those CIN rates in older women. This is 20 to 24 and 30 to 34. Again, suggesting that perhaps this younger age group is at more risk for developing CIN3 and cancers. So in summary, most agree in the US that screening before 21 years of age is not cost effective and may result in harm. The screening between 21 and 25 is more controversial. Without population-based screening program in place in the US, there is a rationale for younger age of onset of screening. And certainly our biggest challenge will be coming up with screening among HPV vaccinated women, but that's another story. And this is a plant in my office that acquired the plant papillomavirus. Okay, I'll hand it over to Peter.
Thank you. Now we'll hear from Peter Sasieni.
Thank you. So I think Barbara's really summarized the science. HPV infection and CIN1 are very, very common in young women, and cervical cancer is very rare. And cervical screening is not without its harms. There's a huge amount of anxiety associated with a positive screening test, and there's a possibility that treatment can cause preterm birth in subsequent pregnancies. And there's also evidence that cervical screening does not work very well in young women. It's interesting to compare to Marc's talk and think, if you want to have an evidence base for guidelines as to whether to start screening at 21 or 25 or 30, do you have any randomized controlled trials? Absolutely not. But going through his criteria for making guidelines, there's actually very little evidence to base it on. And yet the guidelines claim they're evidence-based because they're making a decision about when to start screening without considering whether we're considering at one age or another age. And so actually these rules for how to make up guidelines don't apply very well when you're looking at 20 versus 25 for the age of starting screening. So to say, in North America, you've got the COG guidelines and the US Preventive Task Force saying start screening at age 21. And you've got screening programs, for instance, in Manitoba, that says 3 years after sexual debut or from age 18. I think it's whichever is later, but it's not quite explicit. By contrast, the European guidelines that Marc wrote says cervical screening should start in the age range of 20 to 30, but preferably not before age 25 or 30. So they're suggesting older than the Americans. But actually, these guidelines they have no legal basis, and each country does its own thing, as you can see by this map, which Barbara kindly gave me. You've got from age 15, in fact, in places like Luxembourg. Sorry. Yeah. So in Luxembourg, age 15, and going up to 30 in parts of Eastern Europe and Finland and the Netherlands. And even within countries, there are different policies. The United Kingdom has a different policy in England where it's 25, from Wales and Scotland where it's 20. So if you think about screening and the natural history of cervical cancer over a lifetime, if you take 100,000 women, probably 80,000 of them will have HPV infection. Perhaps half of those will develop CIN1, 8,000 CIN3, and about 2,500 will get cervical cancer. So on that basis of 80 to 2.5, screening and intervention to prevent cancer seems very worthwhile. But if we think about what's happening under the age of 25, probably at least half of those HPV infections will happen by age 25. So we might have 40,000 women who are getting HPV infection, 20,000 with CIN1, 5,000 getting CIN3. We know those numbers are true from where we screen women intensively under the age of 25. But the greatest number of cancers in that age group is about 1 per 10,000 cumulatively up to age 25, so 10 per 100,000. So there's the problem, that if you treat 5,000 CIN3s, you may only prevent 10 cancers. And the real issue is that, unfortunately, we don't have any treatment for HPV infection per se. If we did, if there was some sort of vaccine or antiviral, then it would be quite fine to screen much younger in order to stop HPV infection in its tracks and prevent that progression to CIN and invasive cancer. And it should be a general principle with screening that you screen as late as possible to minimize overtreatment. If you could know exactly a week before something would turn from CIN3 to invasive cancer, that's when you'd like to screen so you can prevent it just before it happens, giving as much time as possible for anything that is reversible to reverse. And so the issue of when to start screening is really a balance. How many women are you willing to treat to prevent one cancer? Or how many are you willing to treat to diagnose a cancer as a stage 1A1 rather than a 1B? So we only have one place where we've actually changed the screening program very formally, and we can see what happened when we took away screening from women aged 20 to 24. And did it have a terrible effect, which is what a lot of people predicted? And these graphs show you in England, where screening used to be from 20 and is now only from 25, starting around 2004, the change happened, with the other three parts of the United Kingdom where screening continued until, from age 20 until very recently in Northern Ireland and still in Scotland and Wales. And in blue is cancer rates in 20 to 24-year-olds, and you can see that if anything, they have fallen in England, and nothing to suggest that things have got much worse in England compared to Scotland, Wales, or Northern Ireland. And there's been an increase in cervical cancer in 25 to 29-year-olds in England, but so has there been in Scotland and Wales. If we look at this slightly differently, each of these little graphs is a different age group, 20 to 24 to 45 to 49 on the first row, and then older women in the second row. And you can see in the second row how dramatically cervical cancer rates have fallen in older women. But you can also see this huge increase in 25 to 29-year-olds, the second plot from the left on the top, where cancer rates have gone up dramatically, so that now cervical cancer incidence is almost at its peak in 25 to 29-year-olds in England. So you can see that it would be completely unacceptable based on this to follow the Netherlands or Finland and start screening at 30, because actually you've got almost as high rates in 25 to 29-year-olds as in any other group. But also shown on this is what's happening with more advanced cancers. And so the yellow is the age distribution of stage 2 or worse cervical cancer. And that's probably what the age distribution of all cervical cancer would look like without screening intervening and changing that natural history. And you can see that that peaks in 80 to 84-year-olds, a very, very different curve than the white ones. So what happens if you screen 100,000 women from age 20 compared to 100,000 from age 25? And this takes into account the fact that not all women will come for screening, and the screening from age 20 is very much based on what's going on in Wales at the moment, and from age 25, comparing it with England. So there would be about an extra 120,000 screens done between 20 and 26, based on screening from 20. There'd be about an extra 24,000 non-negative tests, so women being told you've got something that's wrong, you either need to go to colposcopy, an early repeat, about 9,500 extra colposcopies, and in England and Wales, where we treat CIN2 as well as CIN3, there would be nearly 4,000 additional treatments. So that part is all very easy. Then there's a question of well, how much difference does it make in terms of cancers? Well, we know that in Wales, most between age 20 and 26, in 100,000 women, there would be about 50 cancers. And there's no evidence that there's any reduction in those cancers by screening from age 20. There is some evidence of a reduction of a stage shift. And potentially there could be 5 additional cancers found at stage 1A by starting screening at 20, and therefore 5 additional stage 1B or worse cancers if you don't start screening from age 25. So that's 5 down stages for treating something like 3,700 women. So the two perspectives, one is a kind of scientific or a health economic thing. Screening women at age 20 does more harm than good. Huge number, 3,500 treated to down stage 5 cancers. And the other is the individual woman who might say it's a price worth paying if even one life is saved. But I think the real issue is, if you're going to screen from age 20, what do you tell the woman? Is it unethical to screen, say, come and be screened, it's great, without telling her, actually, you've got a certain chance of having an abnormal screening test, a certain chance of having treatment, and the chance that you benefit from this is really minuscule. Thank you.